think I know most of the people in this room, but just in case, my name is Darrell Gabauer. I'm Vice President of Finance and Administration for the college here. And I am happy to be able to represent and present something to you that we're very excited about. For a number of years, we've been kind of kicking around the idea of having a medical clinic here on campus. And we just couldn't get the right fit for it. And a few months ago, Dr. Ray White came to us from Mercy and with an idea that Mercy run a clinic for us if we could provide them with space and obviously with patients, and that's your job. So, and as we looked at this, it looked like a really win-win situation. We could provide affordable and available health care for our students and our employees, and Mercy could develop long-term patient relationships. So it really sounded like something that we really wanted to look into. We're still in very early stages, but wanted to give Mercy an opportunity to come and make a presentation to us and to answer any questions that we have. We've got the room here for an hour and a half. I think the presentation might take 25-30 minutes, and then we'll leave the balance of the time there for you to answer questions. And as I said, we may not have all of the answers for you, but we're going to be seeking information from you over the course of the next couple months. And our goal, if we can get this off the ground, would be to have a clinic here and open by the start of the next school year. So with that, what I'd like to do is I'd like to turn this over to Dr. Ray White, and I'll let him introduce his constituents and make the presentation. Right.
So as Darrell mentioned, I'm Ray White. I'm a family physician with Mercy. I've been with the organization for about 10 years now. It's a little bit of a homecoming for me. I grew up in Barnhart, still have a lot of friends there, still spend a fair amount of time in the community. When I'm not seeing patients, I also serve as our medical director of the South region, which encompasses all of Jefferson County and southward. So when we first came to Jefferson and talked to them about a partnership, it was actually based around how do we enhance each other's educational opportunities. So the college does a great job of educating young health professionals, but how could we offer, for example, clinical experiences? And that conversation went well, and then Ray and I, just as much as Darrell alluded to, as Ray Comiskey and I were sitting at lunch, just started talking about, well, what other ways could we broaden our relationship? Could that clinical relationship extend to students? Could that extend to faculty, staff? And what would that relationship look like? The rumor is true that healthcare is changing very rapidly, and within Mercy, one of our challenges is how do we respond to that? Whether those are governmental forces, whether those are just our aging population, whether that's people getting insurance that have never had insurance before. We want to stand ready and be at the forefront and be able to address those needs. And I feel Mercy is well positioned to do that. Probably ought to start by just a quick introduction of who Mercy is, and I'll only spend about 90 seconds on this because I do think it is important. I know Mercy is relatively new to the community in some ways. But Mercy is actually we're present in 7 states. In Jackson, Mississippi, we have a group there that serves mostly as a way of being advocates for women and children with the state's legislature. In New Orleans, we have a mental health facility. As you can imagine, after Katrina, they are very busy, spend a lot of time doing especially pediatric psychiatry there. Also have a presence in Laredo, Texas. We used to have a hospital there that was sold, so we still maintain a presence there as well. And the main 4 states we serve are Oklahoma, northern Arkansas, Kansas, and as much as I'm a Mizzou graduate and love Missouri, the people in Kansas really do need health care, so we do help them out on occasion as well. And then obviously in Missouri, we're certainly one of the largest employers in Missouri. We're the largest employer in Jefferson County. Incidentally enough, the college is the 2nd largest employer, so again, makes for a good partnership. So what is the vision here? Well, to me, the fundamental question that we all face in healthcare is addressing a certain healthcare equation, if you will. How do we, and it starts with the fundamental question of how do we deliver a healthcare that people want, plus the healthcare that people need, where and when they want it. And we use that definition very carefully because we thought about it a lot. Let's face it, none of us in the room want to go get a colonoscopy, but from time to time, we do need these services. We never want to get sick, but how do we make that care as convenient as possible? you can't make that more convenient than being in the place where people go to school, or certainly where people work. So that's where the brainchild of this came about. We do have organizational experience around this. We're doing this at Missouri Baptist. We also have partnered with employers here in the St. Louis market. That's with the Merritt's Company, and the team will talk about that a little bit more here in a minute. So, with that, I would like to introduce our team. Vice President of Operations, Ted Franzak. Tracy Reardon, internal medicine physician, one of my colleagues from college. And then Lisa Young, she is our Director of Corporate Health.
That's right. So we're going to move through these slides fairly quickly today so we can get to really the questions that you all have. But as we talk about healthcare and developing partnerships, we are very excited to be going out and talking with individual employers across the organization or across our community. As Ray already said, we have partnerships with Merritt's and Missouri Baptist University currently. We're in conversations with many other organizations across what we call our East region here, which is St. Louis, Washington, Jefferson, and the immediate area. But our goal is to develop lifelong partnerships, not just occasional partnerships. So an occasional partnership is you see somebody in the hallway, you say hi, you keep walking. A real partnership or a real relationship for that matter is whenever you see somebody in the hall, you say hello, you say, hey, how are you doing? And you actually and genuinely care how that person is doing. So when we develop Mercy Clinic at Work partnerships, we don't want just one organization to be successful. We want both organizations to be successful. So that's the word that I'll use continually throughout our time together today. The other word that I'm going to use a lot is word flexibility, because Mercy Clinic at Work is really not just a one-size-fits-all. I would say the models that we currently have are very different in both of the institutions and with other organizations. We can develop a Mercy Clinic at Work strategy that would suit that individual employer or university, and that's what we're looking to do. So, as Ray said, healthcare is changing, and we at Mercy see the writing on the wall, as many others do across the country, but we want to make sure that we're doing the things that patients are wanting of us. And in fact, we need to do more listening and then strategize based upon what patients are telling us. We want to change the way people feel about healthcare. You know, when you call a physician's office today, hopefully we don't make it too difficult to get in to see your doctor, and hopefully we can do it in a convenient and timely way. But I will tell you, after working with doctors for the better part of 13 years, we don't always do that in healthcare. In fact, we sometimes put the biggest challenges, we create the biggest challenges ourselves in order to try to take care of patients. We need to remove some of those barriers and remove some of those challenges and make care more convenient to where you all find that relationship that you're developing with your individual provider, whether it's a physician or whether it's an advanced practitioner. We want to make sure that you see that as value. That's where we develop those strong relationships over time. We also want to make healthcare very comprehensive. So historically, healthcare in the United States has been very fragmented. In the world of an EHR, electronic health record now, healthcare is becoming a lot more integrated. Certainly within Mercy, we'll talk a little bit more about that later on, but certainly within Mercy, we have a way of really connecting the dots, if you will. So for patients, when they seek healthcare services in a primary care physician office, we know exactly what's happening whenever that person needs to go to a specialty physician, or God forbid that person would show up in an emergency room. We know, because of our electronic health record, how and what's going on with that particular patient, whether it's diagnostic testing that you've received, whether it's medications that you're on. We want to make it very comprehensive so whenever you seek healthcare services, we get the total picture of what's going on with you as an individual and not just a little snapshot in time. We think we can deliver high quality care if we continue to do that. So we want to make sure also that you guys and your families, more importantly, find the health care that we are delivering to be value-adding to your families. We, as Mercy, deliver services in a lot of different areas throughout our East community. Most recently, we've developed our relationship with Jefferson Hospital down there, here in Jefferson County, and we're developing a pretty robust manpower strategy in order to develop even more relationships and to have more physicians be part of Mercy. We think the better that we can do that, we can change people's perspectives about Mercy, have us better well known, but also have us well known for delivering the high quality services that you expect, not only out of us as an organization, but as individual patients. So how do we plan to do this? I mentioned that we want to do that through our electronic health record. Our electronic health record is called EPIC. We have a term that we use, one patient, one record, and so we do know everything that you have those conversations with your providers about. So whenever you do show up in those different venues of care, we're able to provide the most timely, the most cost-effective care, and prevent duplication of services too. Historically, within the healthcare world, if you're seeing multiple doctors, maybe of different health systems, as much as we have tried and done an okay job within our healthcare community, we haven't always been as coordinated as we can. But through our electronic health record, we can certainly do that. We want to reduce the barriers. So I mentioned whenever you call the physician's office, sometimes you say, I want to see my doctor. Well, that person may say, well, we can get you in 4 weeks. Well, that really isn't going to help your ear infection 4 weeks from now. We need to be able to listen and provide better access to you all as patients and certainly customers of the organization. The biggest thing that we want to do, though, is develop relationships. Talking with you all today is our first attempt, actually second attempt, because this is our second time here talking with a group such as this to develop relationships, not only with Jefferson College, but with you all as individual patients. We think if we develop those relationships over time, that's loyalty. And we have an expectation to provide you with high quality services, but sometimes the physicians have expectations of you all as patients too. If you have a sound relationship with that provider, you're more apt to follow sometimes those difficult regimens of taking pills or doing rehab or exercising. It's all important. The last thing on that list is really what the government is asking us to do, and really what all of us as individual patients, us Mercy folks included, are wanting out of healthcare. We want to reduce the cost of healthcare, and we want to provide higher quality. Through our electronic health record, with our way that we can coordinate services better, with providing better and more convenient access, we believe that we can do those things. So our Mercy Clinic at Work site is really just another strategy for us to be able to do those two things: reduce cost and provide higher quality care. So you all, as patients, have asked for us in healthcare to deliver better access. And we have lots of access out there. We have physicians' offices, we have diagnostic testing areas, we have hospitals, we have urgent cares. We have a lot of different access points for healthcare. Some of them are convenient, many of them are not. Our goal with Mercy Clinic at Work is to, instead of having patients come to see us, we want to go to where you spend the majority of your time. Whether you're a student or whether you're faculty here at Jefferson College, we want to be able to come to you. One of our cardiologists, as we were talking strategy a couple of years ago, he said, we need to go where the patients are. Mercy Clinic absolutely fits in with that strategy, and that's why we're here today. Dr. Reardon?
Thank you. Before I get into this slide, I wanted to let you know I have been a physician for 10 years at Mercy. I went to residency over 13 years ago and have seen the transitions that Mercy has gone through. And I can tell you that becoming an integrated facility has greatly improved my ability to take care of patients. When a patient goes to the urgent care, I am easily able to see what happened as long as it was a Mercy urgent care. There have been times when I've had a patient come to my office because they haven't gotten better from their sinus infection, and I ask them, well, what were you given? And they say, I don't know. Well, if it's a Mercy urgent care, I know exactly what happened and what was given. So the continuity of care is improved, and the same thing happens when they see our specialist. The reason this is really important is when you have a Mercy Clinic at Work here at Jefferson College, it comes with our integrated EPIC, our electronic health record. And there's a lot of benefits for patients too. They're able to send messages to the physician. They can do something called an e-visit, where if you have a sinus infection or something, you can actually get online and send a message. Rather than maybe making an appointment, it just depends on what the needs are. So Mercy Clinic at Work will also have all these other benefits with it. When Ted and I were coming up with a plan on how to implement this, to me it just made sense. Our healthcare costs are going up, up, and up, and despite that, we are getting sicker as a population. Our emergency room visits, only 11% of them are actually considered emergencies. 40% are considered non-urgent or semi-urgent. So those things could be seen by the primary care doctor or other venues of care. However, because of access, they end up going to the emergency room. So Mercy Clinic at Work hopefully can capture some of those semi-urgent, non-urgent, or even some of the urgent care illness. But the other important piece of Mercy Clinic at Work is helping with prevention and management of chronic illness. Again, as a population, we're actually getting sicker. Part of that is because we're getting heavier as a population. A third of the population is considered obese. Diabetes, the number of diabetic patients will double by the year 2020. So as you can see, there's a fairly high prevalence of chronic disease in the working population. 39% of the working population has at least one chronic illness, and this is between the ages of 18 and 64. If you're looking at the population between 50 and 64, that group of patients have at least 4 chronic illnesses. These are conditions that if we intervene and treat at an earlier stage, we can prevent the heart disease, the end-stage renal disease, congestive heart failure. But these patients need to be seen more than once a year. And there's lots of my patients who actually take off a full day of work, a half day of work, or worse, they don't even show up every year to get their appointment because it's just not convenient. So Mercy Clinic at Work can be an access point for those patients who need management of their chronic illness. And this slide is really meant to show you that it does work. If we intervene on these conditions, asthma, congestive heart failure, and diabetes, we actually are saving money, and the return on investment is sometimes less than a year. Congestive heart failure, we can save $3,900 in just under a year by aggressively managing these patients. As you'll see, depression actually costs a little bit more, but I would argue that depression is very complicated and comes with a lot of other chronic illness, and it probably needed to spend more time than just the 1.1 year to evaluate this, and we probably would start seeing improvement. The other thing that this does not capture is how many days that we save the patient from taking off due to illness, and how much time the patient didn't have to take to make their appointments. And then, of course, being on campus here, we'll have a student population. We'll also need to address those needs. I pulled up some facts of, the illness that students have is a little bit different than our older population. Unfortunately, binge drinking is pretty prevalent in this population with 28.2% binge drinking. It's actually the most abused substance in the United States. And of course, binge drinking leads to other complications such as rapes, sexual violence, car crashes, spread of HIV, and unintended pregnancies, which can all impact their ability to succeed in school. So we'll make sure that we staff these clinics with clinicians that are able to address these issues for students. Other identified problems in this population is sleep deprivation. We want to make sure that we encourage our patients who visit us in the clinic to have healthy behavior, and that includes getting adequate sleep so they can maintain good grades and good relationships. 95% of patients who have an eating disorder fall within the age of 12 to 25. 25% of college-age women actually admit to binging and purging behaviors. And the mortality rate of anorexia is actually 12 times higher than all other chronic illness for this age group. A third of our college population suffer from depression, and a fourth of those students will admit to having suicidal thoughts. So it's going to be important for us to identify these problems in the students that are visiting us in the clinic so that we can intervene at an earlier stage and hopefully have better student retention. So as college is a very exciting time for students, it also has a lot of responsibility that can create some anxiety. Depending on how the students cope with those new stressors and anxieties will depend on how they succeed in school. So we're hoping that it doesn't lead to drug and alcohol use and other poor behaviors. But as we will be a partner with Jefferson College, we can even go beyond just the one-on-one interaction, but help intervene as a group and promote some educational seminars and campus-wide campaigns to help improve behaviors so that we have a healthier older population as time goes on. One of the things we've considered doing at Merritt's and Missouri Baptist University is actually bringing in some of our specialists, OBGYN for example, and having them come and talk with the students or the faculty at Missouri Baptist University about particular areas of concern that they have. So that's something else we're able to offer Jefferson College as well. And I think I'm going to turn it back over to Ted.
So I'm sure by now you guys are asking, so what is this whole Mercy Clinic at Work thing? What does it look like? Well, I can tell you it's going to look something very different at each location that we partner with. Here, we've had some initial conversations with the folks here, some of the faculty at Jefferson College. And what we do know is we want it conveniently located. We want it here on this campus. We want to make sure that you have full access to the menu of services that Mercy can bring forward here to the Hillsborough community. And what we want to do is figure out how to staff it. So we have lots of doctors within Mercy Clinic here in our East community. Today we have about 600 physicians of all different specialties all throughout the metropolitan area. So that's primary care physicians and specialty physicians, the ones that I work with primarily. But we can also bring in advanced practitioners, nurse practitioners, to help staff the clinic as well. What we're trying to do, and what the faculty is trying to do, is who would actually use the clinic? So if we come here, we have great doctors that staff our other locations, they wouldn't be busy. Their job is to be taking care of patients. So we got to figure out, the collective we need to figure out, what does that patient population look like? Is it just older adults? Do you guys want us to be able to take care of kids? Do you have daycare here on campus? Do you want to take care of spouses? Those are all things that will help us decide what a Mercy Clinic at Work site actually looks like here on this, on this particular campus. So we know some of the demographics. There's about 5,000 students with all the different campuses within the Jefferson College community. We know through conversation that the goal of the clinic would be to take care of not only students, but also faculty. That's exactly what we do at Missouri Baptist University. Originally, they engaged us to just take care of their students. That was their primary concern. But shortly after we were having some conversation, they said, you know what, if we're going to have a convenient access point for our students, we should do that for the people that work at our university too. And so now everybody has access over at Missouri Baptist University. So we know that's what we want to do here at Jefferson College, or at least what we've talked about. And then we want to make sure that if we're providing a convenient service, that everybody would have access to it, regardless of the cost. So we have yet to figure out the whole billing piece. We have some ideas. We know exactly how we do the billing function with our other institutions. But I believe that we want to make sure that we go into it eyes wide open. So We want to make sure students have access to it, whether you have insurance or whether you don't. And the faculty and other coworkers here at Jefferson College have the ability to be able to access that physician or nurse practitioner here. So in our last session that we had in this particular room, that billing question came up a ton. And I'll be repetitive, and I'm sure I'll say it again. We don't have the billing piece worked out yet. But I promise you, before we ever get to the point to where we're opening the clinic, you will have as much information as you need in how the clinic's going to work here on this particular campus. And again, flexibility is key, and we as Mercy want to be flexible, and so does the college as well. So what type of services could we offer here? That font's kind of small, especially for you in the back. The goal was to take care of people that have acute care illnesses. That's easy, the colds, the runny noses, the ear infections, all the stuff that you would typically go see your primary care physician, or maybe go to see Walgreens, or go see somebody else in terms of urgent care. That's one model of care, and we can do that very effectively. But as Tracy clearly indicated, where the rubber meets the road and where we can have the biggest impact is to be able to help you manage those chronic care conditions. So whether you have diabetes, whether you have congestive heart failure, whether you have high blood pressure, you should be, if you're not already, going to see a doctor for those fairly routinely. In some of our other relationships that we've developed, we've identified those people and they didn't even know that they had those particular disease states. We can help you with that. But if our goal is to reduce healthcare costs and improve quality, we want to get to that point. So absolutely, we want to be able to take care of the colds, but we want to manage your chronic disease as well. And that is a relationship that you have to develop with your provider in order to do that. And then there's other things that we can do that we've done in various universities, bring out and do mass vaccinations, whether it's flu shots or hepatitis or those types of things. In some of our other organizations that we partner with, we can bring a mammography van out to you, so females could actually get their mammograms right here on site. There's a lot of different resources that Mercy has access to, but we'd have to figure out those things mutually. So I talked about if we're developing a partnership and we really want this to be a lifelong relationship, what are the benefits to Jefferson College? What are the benefits to Mercy? So the benefits to Mercy is easy. We're hoping to provide you with convenient care. And if you like the convenient care and the high quality providers and the service that we're able to provide to you here in Jefferson College, at Jefferson College, we hope that you'll access Mercy physicians and other venues of care, other places throughout the community. That's our goal. That's our benefit. The goal to you is having a doctor or a nurse practitioner right here where you spend a good percentage of time. So I was a student once, a while back, spent a lot of time on campus. I, as a co-worker of Mercy, spend a lot of time, sometimes too much, time at work. So I know what it's like to spend long hours in one particular venue. And taking a half day off work sometimes is a little inconvenient. We do it in order to get the treatments that we need. But if we can provide a convenient access point, hopefully we can limit your time away from those activities which are important to you, either studying or attending class or working here at the university. We want to be able to manage those preventive diseases as well. And again, for those of you that may have those diseases, we want to be able to develop a plan with you, not only just for the year, but for the next 2 years and 3 years and 4 years. We want to develop a lifelong plan because if we're going to have that relationship, it's important for us to do this because we want to see you healthy. We want to see you when you're sick, if need be. But we want to know when you walk out of that doctor's office or that nurse practitioner's office that there's a full understanding of what you need to do as a patient in order to improve your health and stay out of some of those more expensive venues of care and a lot more complicated venues of care, whether it's in the emergency rooms or ORs or that type of thing. The last thing that I want to talk about on this particular slide is the last word on the page. So is there anybody in the room that knows what the word presenteeism is? Got one person? Okay. So I didn't make it up, I promise. Although I've been known to make up a few words periodically. I didn't make this one up. But as we were putting together our Mercy Clinic at Work strategy in our program, we stumbled across this word. And so this is Ted's definition of presenteeism. So if you wake up in the morning and you really don't feel good, but you don't feel bad enough to stay in bed, you take some over-the-counter meds, you go into work or you go into school, and you show up and you're going, oh my gosh, I just feel horrible. I can't even think today. I don't even know what that person's talking about. We do that all the time. Whenever you feel like that, my guess is you're not giving 100% to your studies. You may not be giving 100% to whatever work you're doing here at Jefferson College. Presenteeism is the ability for us to intervene, and whenever you are here at work, you're giving 100% or 110%. If we have a Mercy Clinic at Work site here on this campus, and you show up to work or you show up to school that day, you don't feel good, you can walk in to see the doctor or the nurse practitioner. Maybe it warrants a prescription, maybe it warrants something else, but hopefully sometime throughout that morning, certainly I would hope by the end of the day we can have you feeling a little bit better. Now, we don't have magic and we can't wave a magic wand and make everybody feel better overnight. But you know yourself, if you take over-the-counter meds in the morning, sometimes you do feel a little bit better as the day progresses. We want you to be able to be 110% while you're studying, or be 110% when you're working here. That's going to benefit the college. That helps us take better care of you. And again, helps develop those relationships that we want to over time. So with that, we're going to pause, and all of us will be up here to answer any questions that you may have. I think we have roughly about 50 more minutes to be able to do a little Q&A. So everything's out there on the table, and so feel free to ask us anything that you'd like. Yes, ma'am.
What do you envision as far as staffing this? Like, is it 9 to 5, 5 days a week, 7 days a week, or?
That's a great question. So again, that probably goes back to the flexibility that we need to have as Mercy, and really what you all want in terms of services. So let me give you an example. Our relationship with Merritt's Corporation right now, we are there 3 days per week, 5 hours per day. We have 2 physicians that staff that particular clinic. That was based upon what Merritt's was really looking for in order to take care of their employees there on that particular campus. Missouri Baptist University right now, we have a nurse practitioner that's there 2 days per week, roughly about 5 hours each of those days. That was their desire to take care of their students and their faculty. So what we ultimately decide here at Jefferson College is really based upon the input that you give us. We don't want to be here if nobody's going to use us, but we want to be here to be convenient for you also. So I think it really is going to be up to both of us to mutually decide that. And I can't sit here and tell you that we have a definitive plan. I know when we first started talking about developing the clinic, we said, oh yeah, it should be 5 days a week, it should be open 8 hours a day, and that may not work right out of the gate. It could be something to aspire to. But what we've kind of talked about, at least informally, is starting out on a small basis and then scaling up as we see the need for more services over time. Now, how small we start really is the question that we're going to have to decide upon before we get this up and running by next year. So I didn't try to talk in circles there, but we don't have those exact facts right now, but we can develop a model that hopefully will accommodate everybody.
And Kathy, one of the things that we talked about at the last session was to go out and prepare a survey and really get feedback, and hopefully the people are going to help us prepare that survey and ask the right questions. And we'll get information on what it is that everybody really wants and try and design the clinic and the staffing around that. Because that's the only way it's going to work, is if we can put something together that people will come to.
Right, we don't want to just get the hours right, but we want to get the breadth of services correct as well. Whether that's a wellness program, whether that's purely for more acute care type needs, sore throat, ear infection, twist my ankle type things. We truly want to extend an ear to the voice of our patients. So to reiterate what Ted's saying, a lot of that is yet to be determined, and it's yet to be determined simply because we haven't had that voice heard yet.
Well, let me add even another wrinkle into it. It's also going to depend on what you guys ultimately need in terms of taking care of you, your spouses, or for your kids. So to use an example, Dr. Reardon is an internal medicine physician. She typically sees older adults. That's her specialty. That's what she was trained to do. She was not trained to see young kids. Dr. White, as a family medicine physician, he can see little kids all the way up to older adults, so he can see the full breadth of patients out there. So what we ultimately decide upon and who's going to access care on this particular campus will also determine what type of provider that we have here as well. And maybe that also adds into the question of what hours and what days and those types of things. Other questions? Yes, ma'am.
I know you said the billing is all yet to be worked out, but I guess the question I have is, as these relationships are developed and more people, start coming to the clinic for their needs, is a goal of yours that there would be an exclusive relationship with the college, that all healthcare would be provided through Mercy for our employees?
So I don't think we've gotten to that point yet, or we will get to that point. I think the goal, at least initially, is establishing a clinic that everybody has access to. I don't believe that there is any conversation that we've had that's using the word mandatory. Nobody likes that mandatory word. Nor do we, as Mercy, want to take you away from your healthcare provider. At the last session that was here, there was a lady that was talking about, well, I've got a great doctor. The doctor's in Kirkwood. And I said, well, that's fine. I said, is it a Mercy doctor? She said, no. I said, well, we got Mercy doctors in Kirkwood. So we're happy to explore those relationships with you and steer you in the direction of Mercy if that's your desire. But we truly don't have any goal of interrupting the relationship that you have with your provider, especially if you're happy with that care. And we want to provide and augment the care that you have access to. That's our goal.
And as physicians, we know how important it is for that continuity of care. And with our electronic medical record, it's pretty easy to shoot a copy of the note to your primary care doctor so that they know what's happened. And so we have that ability, and the goal isn't, what we hope is you end up liking who's here on campus and eventually want to switch over, but that's not mandatory. And we can work with whoever your primary care doctor is to manage your illness.
And although it's not mandatory, we do have a bias towards having Mercy doctors take care of other Mercy doctor patients. We work very hard to recruit quality physicians all throughout the area. Ray, in particular, right now is working hard to recruit physicians to Jefferson County. And so we do have a bias towards the physicians that work in the organization. We have a term called Mercy Fit. It sounds a little subjective, but we use it all the time. In fact, Ray and I were in a meeting just earlier today, and we were talking about a particular physician, and we use that term Mercy Fit about bringing in people that truly have the goals of the organization, which is to reduce healthcare costs and provide high quality care, but also just to make sure that they can help us develop those right relationships. And so bringing a physician or a nurse practitioner here to Jefferson College, you just don't pick somebody just because they're employed in the organization. It's going to take a special person. Whenever we developed our relationships with Merits, and we developed them with Missouri Baptist University, we hand-selected the physicians, and the organizations actually interviewed those individuals too to make sure that they are that good fit, because we do want that relationship to be right and then have it be able to grow over time.
And to that point, actually, when we've recruited physicians for Hillsborough, I've asked folks here at the college to be part of that interview process. It just makes sense from Mercy's perspective. Again, after Mercy, the largest employer in the county, plus we want that fit. And Ted hit the nail on the head. It is about those right relationships. I never want to put a physician in a community. I never want to partner with a physician that I would send my own family to. I don't care how much revenue they would generate, how much money they're going to make. It doesn't matter to me at all. Are they the right fit? Would I send my family there? Does that answer your question about exclusivity? Because that can mean a couple different things
Yes.
too. Okay.
Thank you.
Yes, ma'am.
I'm actually a student on campus, and I was wondering, like, let's say I went to the clinic, is there any way, like, you guys would be able, because, like, when I go to the doctor's office, like, if I miss a day of class at work, at home, I take a note back, so when I take a note back, you guys do, I guess, my teachers or
whatever.
Well, I hate to speak for the physicians, but they fill out lots of paperwork, unfortunately. And I know that's not one of the things that they enjoy, but absolutely, that's required.
If it's appropriate,
If it's
you know, we
appropriate.
definitely can write you a note and whatever duration of time is needed if you're ill. But not a free pass.
And the other thing, just because we have a clinic here, we had a young lady last time that was asking a lot of questions, and she actually she goes to school here now, but her hometown is further down in southeast Missouri, and was asking a lot of questions. Well, can I come see you and get my prescription? Well, we can certainly write prescriptions, provided it's warranted and it makes sense. Absolutely. Yes, sir.
I know the whole money thing hasn't been sorted out yet, but again, for full-time faculty, full-time staff, we're insured. I don't see that as being complicated. Effectively, we'd have something like an urgent care facility, kind of from our perspective. But there's going to be a lot, obviously, the majority of our population is things like students, and we've got a lot of part-time people who teach for us. And they're very financially stressed, and I don't know what their level of insurance is. I assume it's quite low. So, you know, you've got a relationship, for instance, with MOBAP. I don't know how you manage that mix. I don't know how you deal with the fact that you've got an awful lot of people who go, oh goody, I can finally get some health care, but of course I don't have any money.
Sure. So, what's the best way I can answer this? Well, we're just talking about what our relationship was with Missouri Baptist University. So they asked us to just build a primary insurance. With most of their students that live, all of their students, let me rephrase, all their students that live right there on campus, they're required to have health insurance. So they've asked us to just build a primary insurance and then do that for the faculty as well. What we talked about with them, though, is if we start to see an abundance of students that are seeking services in the clinic that don't have insurance, that maybe don't live there on campus but commute in, that we might be able to figure out some way to do or bill it to their account or to do some arrangement with the university to where that student still can have access to those services, but yet they don't have to necessarily write a check or swipe a credit card at that particular point in time. So there's various models that we've talked about. We haven't moved down that road yet. Certainly, we could even explore the idea of having a fee here with the college to where it's part of people's tuition. So maybe they're not paying it on a as-needed basis, but maybe it's more of a flat fee that if there was enough interest and enough desire to have access to those services, maybe we could do something like that. So I don't have all the answers, nor has it been decided, but I think there's a lot of models to where we can get pretty creative to make sure that we're taking care of anybody that would show up at the clinic.
And generally speaking, you know, an emergency room visit or an urgent care visit will be much more expensive than utilizing a clinic on site here.
So in Missouri Baptist University, as an example, when they just show up to see the clinic, it's primary care copay. So I don't know your plan design, but I imagine those primary care copays are $20, $25, $30, something along those lines. That's what we would charge whenever we would be here as well.
One of the other hats that I wear with the organization is I represent Mercy in one capacity with United Healthcare, an insurance company. And United Healthcare's data, not Mercy's data, United Healthcare's data says that it's at least twice and probably close to 4 times as expensive if somebody gets their care at a Walgreens as opposed to going to a Mercy facility to get their care. When I first heard that, I mean, I kind of questioned it. I'm biased. I love it. I'm a primary care guy. I would love that data to support what I do day in, day out. But it starts to make sense. If you think about just a simple strep throat visit, right? I mean, a bread and butter, easy visit for a primary care physician. When somebody comes in, you, of course, do your assessment, but you do a strep test there. And then you also send out a culture. Well, if I see that patient back, similar to the story that Tracy gave about, you know, what kind of antibiotic did you get? If I see that patient back in the office, and I have no correspondence from a Walgreens, which they don't correspond to us guys and gals in primary care, all I know is that patient was seen. I don't know what that strep test showed. I don't even know that they ran it. I don't know what antibiotic they were put on. I don't even know if that antibiotic was appropriate. So what am I obligated to do as a clinician? Repeat all of those tests. So that's where that exponential cost goes up. Plus, I can see what their other Mercy providers have done in the past. So let's say this is the 4th or 5th strep throat that they've had in the last 6 months. That course of action may not be just an antibiotic, but it may be actually a referral to get those tonsils out so they're not back in the situation again. So there is a cost savings that's applied, that's I think applicable to students. And let me reiterate Ted's earlier point, this is not a money grab by Mercy in any capacity. And in fact, I mean, we've already talked to the college about if there's a profit to be made there, we're happy sharing that. This is about developing that ongoing relationship. What our win here is to develop that lifelong relationship. That's clearly what we want. We do need to solve for the uninsured population or underinsured population. We do everything, that's part of our mission is to take care of the poor. We've given away or had charity care of over $60 million as a ministry. Believe me, it's part and parcel to who we are as a ministry that we provide for those in need.
Yes, ma'am.
Well, you had mentioned that they wouldn't have to have the money right then at the point of service, and that it would be much less expensive, $20 or $30, but just anecdotally, a lot of our students like $20 or $30. I mean, that is a phenomenal amount of money to them.
Right.
And it's not like they don't have the money just that day, like, they're not gonna ever have the money. And so, I hear what you're saying. I hear what you're saying about if there's profit to be made, okay, we'll share. But I guess I'm more concerned about who's going to absorb the loss, and more importantly, if it is where like it's run through student accounts, if there's like a hold on their account until they pay that, we already have holds on our students' accounts, and then they can't register, and then it could impact our enrollment, or that our enrollment would go down, and then that's how our, so it just seems.
And then they're depressed and their health care goes down.
It just seems like, and I know you're working on the whole billing part, but it just seems like that needs to be addressed as a reality, that really it's not how are we going to show the profit, but how are we going to absorb the cost without negatively impacting enrollment at the college by putting holds on student accounts.
All great points, and there certainly are a lot of what ifs in that many of those scenarios that you just pointed out. But what I would also say is our goal is to make sure that we're providing a convenient service, and really who covers the cost. Really, it's going to be, a lot of that's going to be the volume of patients that we actually see through the clinic, but it'll also be the design of the plan itself, or design of the clinic. So let me give you an example. If we set up a clinic here and we said, we're going to put it up in 7 days per week, 8 hours per day, that's a pretty expensive endeavor. So it's going to require a lot of patience, literally and figuratively on that one, a lot of patience in order to offset that entire cost. But if we scale it back and say maybe it's 4 half days per week, Monday, Tuesday, Wednesday, Friday, whatever the days are, and it's a nurse practitioner, that controls the cost, manages that overhead, gets that down, so there doesn't have to be as much revenue or patients that are coming to the particular clinic. So there's ways that we can design this program, but I think that's one of the reasons why we're here today is it's nice to have the services available, but the goal really is to develop that relationship and have it sustainable over time. So we have to go into it eyes wide open, and what I think the faculty, to their credit, is trying to say, if we're going to do this, we need buy-in. We need people to be able to utilize the service, but we also want to develop a service that you guys want to use. Worst thing we could do is come in here, set up shop, and you go, oh, I never want to see that doctor. Don't want to see him. So I think a lot of it's, we can be smart in how we design the program, and we need your input in order to do that.
And also, remember, part of Mercy's goal in developing these clinics is try to reduce overall healthcare costs. If we can assess someone and find out something that they need help on and maybe get treatment, maybe they won't go in for a triple bypass, in a year or two. Maybe we've prevented that from happening, which if they're uninsured, guess what? That's helped all of us reduce healthcare costs. So that is part of our goal. It's part of our mission.
Other questions?
Does your clinic at Missouri Baptist University integrate in any way with their athletics programs and the unique needs of student athletes?
So we have started the dialogue with them related to that, and there is an absolute interest in going that route. But today, I don't know, can you speak to that?
Right now, they have an orthopedist that they work with that is not a Mercy doctor. So any injuries, sprained ankles, anything, they really want that student to get their care from the orthopedist and the physical therapy that they have. However, the nurse practitioner's on site, yeah, she's going to wrap it, recommend, give them some ibuprofen, take care of the acute need, but long-term management's going towards to the orthopedist. They do want input though when their athletes are sick. When can they go back to sports? Their wrestling organization, when they get a little rash, they got to get that checked out right away and get it treated. So those types of things, yes, we're helping the athletic department. Most of their students, I think it's about 800, are actually athletes. So most of the student population there are athletes and they're using our clinic.
And to that question, one of our global strategies in Mercy East is to develop our sports medicine program. And so I have a strong bias toward making sure that in this relationship, my preference and certainly the organization's would be to have that strong alliance there. Again, growing up in the community, if I couldn't, on my way to pitch for the Cardinals, in my head, I was going to pitch for Jefferson College. Neither one of those have happened, and luckily Plan B worked out okay. But that I think is part of the dialogue, and we would love to provide the sports medicine needs, absolutely.
And I know the gentleman that's over our sports medicine program has already reached out to somebody here.
Baseball coach, who
Yeah,
actually went to
yeah.
high school together, our college. They have a relationship already.
So again, that's a nice synergy that we can provide if we can move further down that road. We still have about 30 more minutes. We're here. Questions? Mr.
And I know the staffing has to be determined, but if it's a doctor or a nurse practitioner, would that doctor or nurse practitioner be the same person all the time, or would it be some kind of rotating?
Great question. And the goal is to have that same provider here as consistently as we can. Now, I say that with a little caveat at the end. Physicians have to take vacation, and they take time for continuing medical education. So there will be times that they will need to be out. And so we'll have to develop a strategy in order to backfill that individual for periods of time, or God forbid they have to go on medical leave. We would have to figure out other ways of taking care of you all as patients. So as much as possible, we would want to be consistent, but there would be the need from time to time to fill in the gaps. Good news is we have 600 physicians that are part of Mercy Clinic, so we have a little bit of a resource there that we can tap into. So.
And to be clear on the nurse practitioner relationship too, they have to sign an agreement with the physician to help support their care. The person that they would sign that agreement with, we would want to be somebody in the community, maybe another Mercy physician. So to that end, the person who came here and interviewed recently, and we had the input from the folks on the ground here. The contract's not signed, but I think we're going to head down that path to be our supporting physician for the community and obviously the college. She's a great fit. She's awesome. So that's the model that we have in mind. If we go the nurse practitioner route, again, we want that support locally. And there may be the need where a nurse practitioner assesses a patient and says, look, this is pretty serious. I'd like my collaborating physician to see the patient, and we would have that kind of relationship as well.
Yes, ma'am.
I guess I'm concerned for the student and the working poor in this community, because there are quite a number of them who are also students and don't have insurance. Is there going to be a sliding scale provision with this clinic? Is Jefferson, or Mercy Jefferson, going to develop a sliding scale resource for people here in this town? I'm just curious.
So, again, we haven't worked out the billing piece. We, at least initially, are not looking to serve the greater Hillsborough community. We are looking to serve the student population and the faculty of people that come here that work here at Jefferson College. So that's the immediate focus of us, and at least of what we've discussed. At some point in time, if it broadens to the greater Hillsborough community or Jefferson County community, then I think we'd have to kind of look at that. But we have at Jefferson Hospital, I don't think that there's any discussions on a sliding scale at this point. Now, what we as Mercy provide is the ability for people to qualify for charity care. Virtually everybody that shows up at one of our hospitals or one of our clinics has the ability to work with folks within the organization in order to qualify for charity care from 100% all the way down to some smaller percentage. And it's based upon their finances, it's based upon need. I won't even pretend to know all the different questions that get asked, but they do have that ability.
And to Ted's point, that's a very robust program. When we started that, I'm thinking, okay, these are going to be people at poverty level or below. The people who qualify for that on somewhat of a sliding scale are well above the poverty level. It's not even close to poverty. So there is the availability for charity care. Is that going to be really part of what we're trying to do here? That's not going to be an emphasis, but we know as an organization we have to have a stronger presence here in Hillsborough.
So there's not going to be that charity care availability here in this program?
I don't know if I can go on record as saying that just yet, because, again, yet to be determined, and I'm sorry to not have that specific. But I can tell you that is part of our global initiative for all of Jefferson County. So even if it works out that it isn't best for this venue, there will be other options for those folks. And again, I'm not saying it won't be available here. It just simply hasn't been decided.
Any other questions? Okay. Thank you all for coming.
Thank you.
Thank you for coming, appreciate it.